Hello, I'm Shazia Durrani, a geriatric psychiatrist. Today I'm going to talk briefly about delirium in elderly. Why do we need to talk about delirium in elderly? It's because delirium can be associated with a functional decline, cognitive decline, as well as a delayed recovery from physical problems. We also know that delirium in elderly can be associated with overuse of antipsychotics. These can have impact on quality of life due to side effects, drug interactions, and increase in frailty, as well as falls. Antipsychotics themselves can also contribute to delirium. Therefore, Geriatric Services Resource Team in Regina created an order set and algorithm for acute as well as long-term care facilities. The purpose is to create increased awareness and promote evidence-based assessment and management of delirium in older population. The objective of this presentation is to recognize delirium, identify risk factors and causes of delirium, its impact on functional status and quality of life, and discuss some of the assessment tools that are available to us, as well as talk about treatment options and goals of treatment. It is important to remind ourselves of some consideration in elderly. We know that in elderly, assessment is complicated by age-related changes, comorbidities, and atypical presentations. These can alter disease presentations, response to treatment, and outcomes. Elderly may not present with increased fever in a state of infection. What is usually more noticeable is a change from baseline function or a change in their behavior. Delirium can be described as sudden confusion, acute confusion state, or cognitive impairment. It should be treated as a medical emergency. What we usually see is a disorder of attention and cognition. What happens is a complex interrelationship between an elderly patient with risk factors and exposure to contributing factors. Delirium usually presents as with an acute onset and a fluctuating course, with associated inattention. There can be disorganization in thinking and altered level of consciousness. In older patients, we would see things like disorientation, sudden changes in memory, perceptual disturbances, evidence of psychomotor agitation or retardation, and disturbances in sleep. In acute care setting, the presentation of delirium is between 10 and 31% in elderly on admission. In long-term care settings, this goes up to 60%. So healthcare professionals who are involved in care of elderly in long-term care need to be aware that potentially some of the patients discharged from hospital may already be in a state of delirium, and vice versa. Delirium can be easily overlooked. Neglecting the baseline mental status assessment is a leading cause for misdiagnosis since acute changes might otherwise be missed. Delirium and dementia commonly coexist. It is important not only to distinguish between delirium and dementia diagnostically, but also to recognize when delirium is superimposed on pre-existing dementia, which has important prognostic implications, including accelerated rate of cognitive and functional decline. Delirium can present in different forms. For example, terminal delirium, hyperactive delirium, hypoactive delirium, and mixed types. Hyperactive delirium is more commonly described in textbooks and easily recognized because it is associated with restlessness, increased agitation, irritable mood, altered perception, and paranoia. Hypoactive delirium is more common in elderly and less likely to be detected. Hence, they are associated with high rates of complications and mortality. Commonly may be misdiagnosed as depressed mood, increased sedation, poor sleep, and lack of response to commands. Terminal delirium also presents towards the end of life when a person is experiencing increased agitation, anxiety, and altered perception. Additional sedation with lorazepam or midazolam may be appropriate if delirium is irreversible. And usually you will find palliative care referral is needed. There are certain other conditions that can mimic delirium, including depression, dementia, and psychosis. It is good to be aware of the differentiating presenting feature in order to make an accurate diagnosis clinically. A number of conditions can present as risk factor for delirium. More importantly, those over the age of 75, those in prolonged restraints with multiple medications, particularly psychoactive substances. We know that physical restraints, polypharmacy, and psychoactive medication can increase the risk of delirium up to 4.5 times. Pain is another factor that can frequently lead to delirium. Dehydration, particularly in acute care, when patients are waiting for certain procedures requiring them to be nil per oral, can lead to delirium. It is therefore important to bear in mind the recent and past medical history, including history of delirium. Use the algorithm appropriately as well as the order set. In the next slide, we will talk about the algorithm, the order set, as well as confusion assessment method, or CAM. Confusion assessment method is a tool that we have utilized in screening for delirium in elderly patients because it has an overall sensitivity of 94% and a specificity of 89%. It has been adapted for use in intensive care units, emergency, and institutional settings. We all know that treatment of delirium is essentially the treatment of the underlying cause that may include treatment of infections, reviewing their medications, or electrolyte imbalances, to name the few. Antipsychotics are only used in those patients who are at very high risk of perceptual disturbances and risk of aggression towards self and others. In older patients, we suggest the use of low dose of haloperidol or atypical antipsychotics. Evidence-based suggests that medications like antipsychotics, which are used to treat behavior symptoms in delirium, are typically not needed for prolonged periods of time. And therefore, we must consider stopping drug treatments once symptoms are resolved. Evidence also shows that most of antipsychotics, once started, are rarely stopped and therefore result in prolonged use of antipsychotics with unnecessary exposure of drug side effects and drug-drug interactions. The Cochrane database also suggests that antipsychotics do not reduce overall length of stay in hospital or improve health-related quality of life outcomes. We therefore suggest reviewing the use of psychotropic medications after a period of 1 week or less. And you will notice that in the order set, the medications are tapered after a period of 4 to 5 days. What is more important are the non-pharmacological interventions in management of delirium as well as its prevention. That includes consistent caregivers, using the patient's name to improve their orientation, avoidance of restraints, paying particular attention to hydration and nutrition, and doing regular medication reviews. We have followed key practice recommendations in assessment and management of delirium in elderly with this order set and algorithm. These include education of healthcare providers and family members, the use of standardized screening tools like confusion assessment method in identifying delirium, assessment and prevention of delirium throughout the length of stay in hospital and long-term care stay, the use of non-pharmacological and pharmacological interventions, as well as suggesting the use of antipsychotics after proper evaluation and for limited time period. Finding the order set is very simple. You need to go onto RQHR intranet and click on PPO tab. Once you are in the practitioner pre-printed orders, you simply type in the term delirium or PPO number 614. The first page of the order set predominantly focuses on effective evaluation of the likely causes, getting appropriate non-pharmacological interventions, and appropriate consults from specialist teams. The second page of order set encourages the healthcare provider to differentiate whether it is hypo or hyperactive delirium. It also encourages that if the patient is already prescribed an antipsychotic for any other indication, to utilize that antipsychotic by increasing the dose. This is to prevent multiple antipsychotic intake in a patient. For patients with suspected Parkinson's symptom or Lewy body dementia, the choice of antipsychotic is quetiapine. For all other patients, haloperidol, olanzapine, or risperidone can be used. You will notice that day 1 and 2 antipsychotics are used on PRN basis. This is to provide optimum response to the minimum dose of antipsychotic. Once that is established, then further treatment can be titrated downwards. Attached to the order set is the algorithm for assessment and management of delirium in elderly. It gives the staff effective assessment tool as well as management strategies of common causes of delirium in elderly, and we encourage you to use it. In summary, early detection and prevention is the key. We should continue to provide assessment of delirium throughout the length of stay in hospital or long-term care facility. The main intervention should be non-pharmacological, and pharmacological intervention to be reserved for severely distressed. Thank you for listening to this presentation.